Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic is OCT and OCT Angiography in glaucoma, and it's being presented by my friend, partner, and fellow speaker, Dr. Greg Caldwell. He's a graduate of Pennsylvania College of Optometry, where he also completed a one-year residency in primary care and ocular disease at the Eye Institute. He is a fellow of the American Academy of Optometry, a diplomate of the American Board of Optometry, and a member of the Optometric Glaucoma Society, and a member of the Optometric Wellness and Nutrition Society. He currently works in Duncansville, PA as an ocular disease consultant. Dr. Caldwell's primary focus is the diagnosis and management of anterior and posterior segment ocular disease, and he has been a participant in multiple FDA clinical trials. He has integrated nutrition, prevention, and wellness into his patient care. Thus, he really practices integrative optometry. He is a co-founder of Optometric Education Consultants and co-administrator of OCT Connect on Facebook. He has lectured extensively throughout the country in over 13 countries internationally. In 2010, he served as president of the Pennsylvania Optometric Association and served on the AOA Board of Trustees from 2013 through 2016. And he's president of the Blair Clearfield Association for the Blind. So with it, let's give Greg a nice virtual internet welcome. And we're going to begin our talk right now.
Perfect. And thanks, Joe. And thanks everyone for attending. And, just like every COPE approved, we got to go through disclosures here. I'll hit some of the bullet points is that this was independently prepared by me. You're going to see a lot of images from OptiView. I'm not claiming any superiority over that. The techniques that I teach can be typically applied to just about every OCT unit that's out there. There are a few proprietary measurements or biomarkers on this instrument, and not saying it's any better. And if there's something proprietary, I'll point it out. You can see I'd lectured Alcon to Hero and Allergan to Inova. I don't really put that out there to really impress everyone, but if you want Joe and I to bring you, clinically relevant information to date, we just kind of stay plugged in with these companies to kind of know what's happening. I sit as involves PA medical director. We're not going to really talk anything functional tonight, so I do have a non-salaried financial affiliation with Pharmanex. When I do their vitamins, I get a commission in a sense. I sit as the PA medical director, credentialing committee and special unit investigation, chairman of Council for Diabetes for Healthcare Registries. And again, no bias and half owner in Optometric Education Consultants, but a new COPE. All of this has been mitigated. All the relationships have been mitigated. All right. So with that being said, I just kind of want to know who's the audience here tonight. Do you have OCT? Do you have OCT angiography or no OCT technology in the office? And polls are rolling in nicely. Great. And remember, everyone, these polls are important because this is what makes it interactive distance learning. So please answer those questions out there because that really helps out making it interactive. So with that being said, I'm going to share the results. And I can see that, majority here, 58% have an OCT. 16 out of the 126 that we've responded have, so that's 13% have OCT and angiography, and about 30% no OCT technology that's out there. So, we'll go with that, and just nice to know the audience here. So, I think what we forget is, when we do OCT in glaucoma is that we go right to GCC and neurofibrillary, and we're certainly going to cover that tonight, show how angiography plugs in. But I think we forget the ability that we could use this to do anterior segment. And so you can use it for pachymetry. And you can see here, I like using this for pachymetry because it really gives me an overall idea of what's going on with the cornea. So we use this number here because if you remember, the Oates study did central cornea thickness. So we just use this number right here, this 575 and 586. You can jump to minimal here if you want 568 and 575. So I like using my my OCT for my pachymetry readings. I keep my ultrasound in the same room, and my technician will do a real quick ultrasound. You really only need it one time when treating glaucoma, just to kind of get that risk factor for, you know, those ocular hypertensive or those glaucoma patients. So I confirm it with ultrasound. And another reason, just so I can build that 765, I think 14 code, that ultrasound. But I'm doing both, but I'm usually most of the time really taking a look at this data here to kind of get an idea what that cornea is doing. And if you remember, you can take pachymetry through ultrasound, you know, and the idea is to try and get this probe right on that center cornea. You could do it through some type of topography. This is an orb scan technology where it does the posterior float and the anterior float using optic sections and bouncing the light off the, in a sense, the, you know, the cornea the tear film, and then the endothelium, and in a sense giving an approximation. The only problem you have to be careful with the optical pachymeters is that if there's cornea haze or a scar, you can bounce back and get a really thin reading. So I think Joe and Lori actually did a study on this, that, you know, doing pachymetry ultrasound versus pachymetry, you know, you pretty much get a thinner cornea thickness every time, because you're really perpendicular here. And, you know, whenever you're doing, you know, this ultrasound here, you know, you might not be in the center, you might be off an angle or two. And, you know, the shortest distance between it is, you know, that straight line, which you're able to do with that OCT and get that central cornea thickness. Joe, is that true? Did you do a study or something like that?
Yeah, my wife, Dr. Lori Bowman, and I did a publication on that where we looked at comparing ultrasound with OCT, and what we found was uniformly OCT pachymetry was thinner than ultrasound, and is also freakishly reproducible, whereas ultrasound really was not as reproducible.
And so I got a question that rolled in here saying, do you find the ultrasound and OCT pachymetry correlate well closely? And yes, Joshua, pretty much to exactly what Joe just said there. What is it, Joe? About 8 to 10 microns. If I read this here, 575 on this patient and 568, the technicians usually come back. It's probably in the 580 range and 570 range. It's just a little bit thicker, just for the fact that she's just not at that perfect perpendicular. Maybe it's just cutting down, like, look at my arrow here. Maybe I'm going to over exaggerate, cutting through this way, getting that 8 to 10 microns thicker. So Joe, no, this is one of my favorite questions out here. It's my soapbox, and I'm going to keep doing it until we see, some resolution to this. And so, you have two men in your office. This is polling question number 2. One has a 500 micron cornea. You do Goldman applanation and you get a 22 pressure. The other one has a 21 pressure. I'm sorry, 21. And the other person that's in there is 600 micron. So you have a 500 micron, 600. They're both Goldman. What's that true IOP that's out there? Is it 18, 21, 24? You don't know. Which way is that? So just a quick question. Another polling question. Joe, thanks for launching the handouts up there. I see them up there. Joe, thanks for doing that study, because Joshua here has thank you. It makes sense, but that's just kind of from the work you and Lori did. All right, let's get those polling questions rolling in. One is a 500 micron cornea, 21 millimeters of mercury Goldman. and 600 micron with 21. What's the true IOP? All right, almost there. And I think we're good to call it. So we're going to share the results here and see what we got. So we have, we have that 500 micron cornea. The general feeling was you have a 21. It's probably, thin, probably stopping that tonometer before you get to that true IOP. I'm going to take two answers here. I'm going to take 21, which is what the majority have answered, or you don't know. That thinking that, that's out there, that it's thin and it's 24, I don't feel bad for the 28 people that answer that, because that was taught for years, right? That, thin cornea, you're probably not getting there. And, you're probably underestimating. And then, that's out there. And then we scroll down here, again, I'll take this 21 and don't know. And then you could see it goes up to be a little bit higher on the 18, thinking that, that cornea was so thick and that, we probably had to really crank on that tonometer. And really the key here is that the cornea is such a complex tissue. We have cornea curvature, you're supposed to adjust that's why it has degrees on there. When you have cornea curvature, you're supposed to adjust that tonometer and take it, with the steep meridian or flat meridian. Maybe Joe remembers that from the teaching in the labs. The cornea thickness, but cornea rigidity, that cornea thickness, that cornea rigidity that's out there, not cornea thickness, but the rigidity. And there's been proven that there are some really thin corneas that are, really, really hard. I'm going to knock on my microphone there. And there's some really thick corneas through the rigidity testing have been found to be mushy. So you're taking this complex tissue and kind of assuming, and what that saying out there is, when you assume, you're assuming that, one element, you're introducing human error. And really, the atmospheric pressure is like 760. I guess it depends on maybe where you live in elevation. Not really an expert in that area, but I know that atmospheric pressure is about 760. So if our pressure was only 18, our eye would just collapse. So it's got to be like, if you got a pressure of 20, it's got to be 780, because the eye would collapse under the atmospheric pressure. So all you're doing is transcorneal IOP measurement. So the key is don't adjust up and down based on the PAC imagery. Here's the key. I'm going to boil it down. Everyone has lungs. Everyone's at risk for lung cancer. Those who are at higher risk are those who smoke. But anyone that doesn't smoke can get lung cancer. Everyone here has retinas. Everyone's at risk for retinal detachments. So who's at higher risk? The higher myopes, the ones with maybe lattice and stretching in that far periphery. So basically you have a high pressure, because remember, that's the ocular hypertensive treatment study, and a thin cornea. I'd say thin is about 500, and high pressure, thin cornea puts you a little higher risk of developing glaucoma. I use 500 and 600, and when it's 550, doesn't really do much. 530, doesn't really do much for me. 570, doesn't really do much for me. So kind of go to the extremes. They have to have high pressure, low, and if they have a thin cornea, a little higher risk of developing glaucoma, and a little thicker cornea, decrease the risk. Joe, anything you want to say on that?
I think you covered it very well. We're really trying to get people away from it. The World Glaucoma Association, their consensus is a thick cornea, more likely than not, will overestimate a pressure. Thin cornea, more likely than that, will underestimate the true intraocular pressure. That's as far as they go. The glaucoma cognoscenti stop right there. So that's all we know about it.
And, I get, I do these live meetings, people will say, hey, I got a letter from the ophthalmologist, or, the other optometrist, may try to be maybe eye care friendly here, and they're adjusting pressures. Well, doesn't mean that it's right that's out there. So don't adjust those pressures up and down. But you know, there's another, we talked about pachymetry. You can measure angles here. And this is actually my angle. Before my LASIK, I was like a -6. And you can see, I dropped the calibers down in here. You can see Schlemm's canal. And you can see how I can measure an angle. I'm over here on my temporal region. You can take this line and kind of approximate that's out there. And my surgeon in the practice, this is not universal. So you have to work with your surgeon, and maybe Joe, you might have some insight where you work, but I like evaluating the angle with the OCT, because you can really turn down the lights in the office, in the room where you're doing it. It allows, as you can see, this iris to kind of dilate because the lights aren't in the room. You can really see what's happening with that angle. And we kind of have this rule of thumb that, less than 15, this is like kind of like how I have it measured here. This is 11.8, 11.28. And if I can just, see the trabecular meshwork or anterior trabecular meshwork, my surgeon will do a laser peripheral orthotomy on that, in a sense, to help prevent, maybe an angle closure that's out there. But, the whole idea is you can measure, with degrees here. But this is not going to eliminate gonioscopy, because I'm literally just looking through this little area. You got to do gonioscopy to be able to look, 360 degrees around. And this was just interesting. Patient came in, with a hyperopic prescription. Pressures now in the eye 50 to 60, and I just took the opportunity here to go, and they had angle closure, and I just ran the line right through here, and you could just see how this, I wish I could have got it over here, but this was an older OCT. Now I have a different OCT, but kind of see how this iris is bending around, touching that lens, building up the pressure, kind of sealing off this angle and this angle closure that we have here. So don't forget, you can use OCT and to look at that kind of iris to cornea evaluation. And with that said,
actually, Greg, if you don't mind going back on that one, as you point out, this is like one cut on a CT scan or one cut on an MRI, and it gives you some information, but doesn't give you everything. Now, if you told me the intraocular pressure was 15 here, I wouldn't be surprised. I'm sure there's iris Bombay, but you've got some open structures here. It looks like there's some closure here that it's more probably touching the cornea than it is really the trabecular meshwork. But you don't know what's happening in the other parts of the angle either. This is good for showing you the iris, lens, cornea relationship, but it doesn't tell the entire story. It gives you an idea of, what do I do next? That with the gonioscopy, I look at the patient and we think to ourselves, well, what do we really need to do? Do we need to do an iridotomy? Especially if it's an asymptomatic patient. Now, Greg, and obviously if there's glaucoma or an elevated pressure, that obviates that question. But when the patients are asymptomatic, it's a little harder to figure out what to do.
Thank you, Joe, for those, for that comments. That's awesome. Joe, I put these slides in. You had these from the other night. I thought that this was, I think you did your glaucoma things to avoid, mistakes to avoid in management glaucoma. I was able to have access to the slides. You sent me these to me, so I thought this would be good for you to talk about. So.
Yeah, and when we do this, of course, it's like plotting the contour line on an old HRT. We're trying to make our determination what we think, but based upon this, we measure with the calipers a 5.38 degree angle. This one's a 6.77. This was a patient with actually in some degree of angle closure, and pressures were, I think, 25 and 35, and the patient was asymptomatic with chronic disease. But this angle to angle, you can actually see how overall narrow it is. It's not iris Bombay, it's just an overall very, very narrow angle. So we look at the intraocular pressure, we look at the gonioscopy, we kind of confirm what we're thinking about here and make a decision. In a patient like this with pressures in the 30s, it's pretty easy to understand that. And the patient was cataractus as well. So it's pretty easy to understand. The next thing we need to do is just remove that lens and kind of solve the problem.
Yeah, surgery is probably the best thing for this patient. So this is backed into angle closure, Joe. Do you want to, backed into closure corner? So you want to talk about that?
Yeah, this was a young woman that I had seen. She's 30 years old, and she was a patient in the practice before I had joined. And in 2018, she was worked up and assessed for narrow angles, and she underwent a laser iridotomy, and it really didn't do a heck of a lot. It was determined that she had plateau iris syndrome. And the top part, you can kind of see that large last roll, the iris. Her chamber is actually relatively deep, but her angles were very, very narrow. So she underwent this procedure, and it was successful. But because it was plateau iris syndrome, it really didn't do a heck of a lot. And I saw her in 2022. She actually came in for a migraine prodrome with her concerns, and realized nobody had ever really solved the situation. And we didn't quite, it wasn't quite clear what to do. So I brought the patient back in the morning. I dilated her and kept her there until the afternoon, and she did not go into closure. So the more we learn about this, the more we're beginning to realize we don't know everything there is about angle closure, and there may be actually be some other approaches that we can do on these patients.
Anything on this slide here you want to chat about?
Now, this is what she looked like if you go back. Now, remember, if you go back to this was pre-LPI. She's extremely narrow. We go to the next one, and this is post-LPI, and you can see that there really isn't a heck of a lot of difference. So ultimately, what I ended up doing was I did dilate her. The options are iridoplasty, pilocarpine, or clear lens extraction on a 30-year-old, none of which seemed to be very viable. So we just bit the bullet and we dilated her, and she understood the risk, and I had medicines ready to address this. And I said I checked her pressure over the course of 4 hours, brought her back a couple times, and she never went into closure. So that's where we stand.
Yeah, these are tricky. You get some of this information here. Sometimes it's hard just to interpret. All right, so that kind of does the anterior segment. Probably we want to dive into what people want to kind of learn about is, this retinal nerve fiber layer and ganglion cell complex. And I like this picture because, it kind of shows us where we're measuring that retinal ganglion cell. Remember, this is a fixed circle. So if someone has a macro disc or a micro disc, that disc might be a little bit smaller. So you might be a little bit further away from this circle. Or if someone has a macro disc, that distance between the optic nerve and the measurement might be a little bit different. But don't forget that, we're talking about the ganglion cell in this area. And this is usually grayed out in that fovea area because there's really no ganglion cells in that fovea. But the point is, remember that ganglion cell is where it houses that axon. That axon now that's what creates that afferent fiber, right? So glaucoma is an afferent disease. So if you get it asymmetric, you can get a pupillary afferent defect. It's that axon that leaves that ganglion cell, goes through that nerve fiber layer, makes that 90-degree bend, goes through the lamina curbosa, through the optic nerve, through the foramen, and it wakes it all the way back to the lateral geniculate body where it synapses. So that's a pretty long axon, and that's the axon of that nerve fiber layer right here that we're talking about. Is this, that's the axon and the ganglion cell. And a lot of people will say, well, which one dies first? Is it the ganglion cell? Is it the nerve fiber layer? And I'm going to say yes. I've seen cases where we've seen, some thinning to the nerve fiber layer, but yet, maybe some thinning showing up in the retinal nerve fiber layer or the axons. So I'm going to refer to this as kind of like the axons, and this is the ganglion cell. Joe, I know you do a lot of reading, and glaucoma is your thing. Is there any evidence out there that ganglion cells before nerve fiber layer axons or back and forth?
The evidence, I think, is pretty compelling that you can get some early changes in the ganglion cell before you may actually see it. And I think a lot of it has to do in the nerve fiber layer, and a lot of it has to do with anatomy and how well these devices pick things up. Now, things are much more oriented and regular in the macular region, whereas when we get further out and we look at the arcuate bundles in the nerve fiber layer, there's a lot of anatomic variability. And that makes it harder for these devices to separate normal from abnormal. But because the anatomy is very regular in the macular region, it's easier to identify some of these changes, sometimes earlier than GCC. But just like the old argument, RNFL, nerve fiber layer disc, or visual field first, the answer is it depends. In most cases, the nerve or nerve fiber layer changes before the visual field in glaucoma. In most cases, not in all cases. And in some cases, we're going to have some issues where the ganglion cell complex will change before the nerve fiber layer, but not always. Sometimes you'll find defects in the nerve fiber layer that aren't really showing up in the ganglion cell complex just yet.
Thank you, sir. Appreciate that. Joe, I'm putting this up because, Kim has asked, doesn't a PI create a safety valve to a plateau iris safe to dilate? I'm going to take a crack and then let you take it. But Kim, usually what happens is, this plateau iris, let's pretend this is way out here. And this is where the closure goes, but they put the PI right here. And so obviously then that PI really doesn't do anything because the closure or the plateau is hitting here. So that's why sometimes Joe's talking about this iridotomy where they can sometimes burn little laser into at least that's what I'm thinking he's doing. I've seen that done where they'll burn little circles with the laser around the iris, kind of constricting it, kind of pulling it this way. But, Joe, you want to kind of fill in the gaps here where it says, doesn't a PI create a safety valve for plateau iris?
Kim, those are excellent questions, and I'm really glad that you asked them. PI only works if there's pupil block, where there's a relative tight apposition between the anterior surface of the lens and the posterior surface of the iris, leading to iris bombé. In plateau iris syndrome, there's no pupil block. Aqueous can get from the anterior to the posterior chamber. So PI only works if there's pupil block, and plateau iris is a non-pupil block angle closure. And it is not common, but it does happen that you can still get a closure after PI. The ones that I've actually seen it happen have been plateau iris syndromes. So PI only works if it's pupil block. I'll give you an example. If a patient is using Topomax, topiramate, and they get this sulfur allergic reaction that causes angle closure and a high degree of myopic shift, putting a hole in the iris, and many people did because they didn't recognize the mechanism, doesn't do anything because it's not pupil block. It's ciliary congestion and anterior rotation of the ciliary body.
Thanks, Joe, and thanks for help clarifying that. So with that, let's go back just to kind of remind. So the idea would be if this is damaged axons, from that ganglion cell, it should kind of correlate in a sense to maybe that ganglion cells in the macular region. So remember, it's the cell body versus the axon that's running. And remember, fluid flows through that axon both ways, from the lateral geniculate all the way back to the body. And then from the body, so it's there's axoplasmic flow going through there. So, ganglion cell thinning, remember there's no really ganglion cells in this kind of foveola area. So we're looking just outside into the fovea. So this is the full retina. You have in the ganglion cell complex, the nerve fiber layer, the ganglion cell layer, and the inner plexiform layer. And that's where these ganglion cells are housed. And we do know that they do get damaged in glaucoma. So this is sometimes I open this up, if I'm scratching my head, did the instrument segment the correct way? And it looks like it did here. It's going down to that inner plexiform layer to that, nerve fiber layer, that internally limiting membrane. You could see nice, healthy, robust. So I like to check the segmentation sometimes. If I'm scratching my head, that can just open it up and take a look and see what's going on. But this was a known glaucoma patient of mine and had a pretty nice, visual field cut. So I just kind of opened it up and I wanted to kind of see what it would look like. And you can see here, nice, healthy ganglion cells on this side. And then on this side here, you can see the atrophy that has occurred. You can kind of see is using this as the normal up here, the atrophy and the disease process of glaucoma. So glaucoma is kind of an inner retina disease because it's damaging those ganglion cells in that retinal nerve fiber layer or those axons. So with that being said, I'm going to put this poll up and I'm going to put this picture up and say, looking at this, this red and this yellow and this red and yellow, I'm not giving you any other history, looking at the ganglion cell complex, is this ganglion cell, that's all I'm giving you, no pressures, no family history, just looking at this, is this ganglion cell thinning most likely from glaucoma? Yes, no, or you don't know.
And Greg, while that is running, and if anybody can't see the picture, you can just right click on the poll, left click on the poll and drag it out of your way. Mark asks, what can be done in the Topamax scenario other than discontinuing the medication? Well, discontinuing the medication is obviously going to help, but the next step would be to use a steroid, probably a prednisolone, about 4 times a day, a good cycloplegic, probably an atropine once or twice a day. And if the pressure is extremely high, you can use an aqueous suppressant, and that will work. All right, that's going to work. And another way you can tell the Topamax is causing it. These are people that get a significant myopic shift to several diopters almost overnight, and it tends to be bilateral, whereas primary angle closure tends to be unilateral. So Topamax, stop the med if possible, and in consult with their doctors, let them know what's going on. If they're using it for seizures, I wouldn't do it. If they're using it for weight loss or headache, I wouldn't hesitate. Steroid 4 times a day, aqueous suppressant, cycloplegic, it will get better, probably pretty quickly. Pressure comes down pretty quick. The induced myopia may take a few weeks to settle out.
And then a question came in. That's a private question, Joe. I'm not sure if you see those or not.
I don't.
But someone came in and asked if someone has ARMD, macular degeneration, non-exudative, what effect will it have on the GCC? And that one's a little bit of a loaded question because it's going to be depending on how advanced the macular degeneration is. And then basically, you have to look at how well it's segmented. So what I do a lot of times for the macular degeneration patients, remember macular degeneration is an outer retina disease, right? Brooks membrane inflammation down here. You could see if there's, you're going to get, if in advance, you're going to start getting some photoreceptor atrophy, which then can then start causing the inner retina to really take on a morphology change. So, it all depends. You just got to be careful that's out there.
Greg, before we move on, Kimberly asked this another great question. Speaking of Topamax, do you do any routine screening like plaque world? The answer is no. When this was all kind of relatively new, I had a colleague at the university who had a patient on Topamax, and she said, yeah, I'm going to do gonioscopy every 3 months on this patient, and the minute they start to narrow, I'm going to get an LPI done. And I said, well, great, but none of that's actually right because LPI doesn't do anything, and it is sudden. Usually this will happen after the first dose, maybe 1 or 2 doses within a week for the most part. After a month, it's extremely rare. I have heard of a case where a doctor just doubled the dose and it caused it to happen, but it's a sudden thing. You don't have to screen like Plaquenil or actually, Greg, I saw one of the hate drugs today. I saw a patient beginning ethambutol, so we had a long conversation about screening for that with a patient. But no, Topamax is sudden. It's usually after the first dose or 2.
All right, so 34 say yes. We have 24 say no. We have 42 that are not sure. I'm going to end the poll. I'm not going to give the answer because I'm going to do a little bit of going through some different things like red, green, yellow, and blue disease, physiologically normal, and maybe circle back to that OCT. So, remember that these OCTs, I think the biggest normative database is like 750. And that's on patients that don't have disease, not high myopia, not high hyperopia, no tilted discs, no obliquely inserted discs. So remember, the normative database is relatively small. And so you can start getting a lot of yellow, blue, and green disease, which is physiologically normal. And, just by doing a lot of OCTs over the years, I've kind of come up with, kind of a few little rules that I use, and they kind of seem to stand the test of time. We know that, disease, glaucoma for particular, is bilateral. But think of it like arthritis or disease in the body. People can have arthritis in their shoulders, but it's usually worse in one shoulder than the other. Elbows, knees, hips. Yeah, I had my right knee hip done first. It was worse 2 years later by my left knee. Usually disease is bilateral, but yet asymmetric. And that's the beauty about glaucoma in the majority of the cases. I'm sure there's a case out there where someone had glaucoma and got that ganglion cell or nerve fiber layer, but usually one eye is, a little bit more advanced than the other, and that kind of helps us out when interpreting these scans. So if the scans are symmetric, then it's most likely not disease. It's most likely physiologically normal. It's probably an anatomical variation, and it's normal for that patient. Another little hint I'll point out, and this is kind of for the OptiView instrument, and it's probably pretty similar for the ganglion cell. We do a lot of wellness in our practice, and before the wellness opens up and it does the GCC, I'll cover it with my hand and I'll say to the patient, look, before this opens up, these numbers should be between 85 and 100, and hopefully they're symmetric. If they're not, we're going to discuss it. And pretty much all day long, I see them around 92 to 95 microns. So that's just kind of, I would say just normalize patients, start doing a bunch of them, and get kind of familiar with your instrument. So, symmetry is, and this is what's being tested here. So what I'm showing you here is symmetry. So in this ganglion cell complex, this is kind of where I cover up the middle at. This is a wellness program right in our practice. We do a ton of them. So I usually start in the ganglion cell complex because that gives me a hint of what's happening out here to the retina. So between 85 and 100, I see, 98, 98, 98, 96, 97. And when I was working with OptiView, I actually helped them to encourage them to put this number in here, not just because I couldn't do the math, but I just wanted to see 2, 1, 2, 0 within the eye, 1 within the eye. And you can see here that I don't get too concerned. I don't scratch my head until I see about a 10 micron difference. When I see a 10 micron difference here between the eyes, I start investigating. Is it a PVD? Is it a vitreomacular adhesion, vitreomacular traction, something causing that asymmetry? Doesn't always have to be glaucoma. I don't always think glaucoma first. I think more retina disease, especially in the older population. This here is very proprietary. I told you I'd point a few things out. I'm not saying the instrument is more superior. This is focal loss volume. You just go by the colors. Green is good, yellowish caution, red is bad. This is a glaucoma test. This is a general health. This is global loss volume. So if someone's a high myope, I can sometimes see these being yellow or red, but the green here is normal, saying it's not focal, because glaucoma is usually focal, drilling down in that same ganglion cell area or into that arcuate area of those ganglion cells. So what this does then is allows me to see what's happening to the retina. This is perfectly healthy, perfectly symmetry. Everything is nice and green. But let's go to this 46-year-old woman with what I call red and yellow disease. This is all going to be normal, right? She is a very low myope. She's taking some thyroid medication. She's got a little high cholesterol. Pressures are 15. That's at 8:30 in the morning. But we come and we look at this patient and we see all this red going on with, you know, her retina scan. But let's take a look at her ganglion cell complex, and I have them both put up here. Check this out: 110, 111, 110, 111, 109, 110. She's got an extremely robust, remember, on this instrument and very similar to other instruments, 85 to 100. I have patients that are 80 and it's normal. 80, 90, 100, 110, 30 microns different. That's huge. So she's above that. So that's making, look, 0 difference, 2 difference, 1 difference. You know, I don't get too concerned until it's 10. Obviously, the focal loss volume, the global loss, this is all good. This is so thick. Look what it's doing to the measurement over here. Green is good. Yellow is red, mean thicker than average. Blue means thinner than average. Look at all these numbers. Look how red they are and yellow they are, but it's because she has a robust ganglion cell complex. Look how symmetric this is. You have 330 here, 329, 359, 364, 350, 352. Everything is symmetric here. You can come up here and take a look at the scans. Nothing's wrong here. Things are symmetric, even though we got a little bit of yellow and a little bit of red disease. And then again, what I point out here is you might have some red disease, but look at the scans. You can see that there's edema. And you can jump over to this one and can see an epiretinal membrane. You could see the cysts that are forming. And again, you'd be able to see in this red disease on this patient that, you know, there is a reason. But when you come back to this patient, physiologically normal, despite all this yellow and red, totally normal for this patient. And you can use that symmetry rules that are out there. This is a 63-year-old woman with red, yellow, blue, and green disease. Pretty much a plano presbyope. 15 to 18 are the ranges, anywhere from 2011 to 2015. Now let's take a look. You see some yellow here, kind of maybe following maybe that arcuate defect, a little bit of island here. But let's go and take a look at I always start with the ganglion cell complex, 80 to 100. And we can see here that we have 83, 81, got a green, got a yellow, got a yellow, got a yellow, both 81, 81, 85, 82, 2 different, 0, 3, 4 difference, 1 difference. And you can see right here, very symmetric, even though we're at the low end. It's even saying, hey, doc, it's not focal, which would be glaucoma. It's more of a diffuse loss, at least in this left eye. And then when you come up here and you look at this, you know, 254, 254, symmetric. It's getting very hard, especially when you go up here and look at the B scans that you're going to have a disease process. So this was next year. I just said, look, we're going to observe this, and you can see even more symmetry. 81, 81, 81, 81, 82, 81, 0, 0, 1, 1, 0, saying, hey, it's not glaucoma, it's just general loss. So they're just outside that normative database flagging it. But the symmetry, even look at this, a backwards C, frontward C. It's almost, if I can just fold that in half, it's almost like a perfect ink blot on this patient. They're so symmetric. Disease typically doesn't do that. So that's just another physiologically normal. Here's a patient. Go ahead,
Greg,
Joe. Yep.
Just going quickly back, and I think it's important to underscore the importance of when you do this, you're able to do this because you're ensuring you've got good quality between both of them. You're looking at the B scans. You're looking for any sort of abnormality, missing data. There could be artifacts that may lead you to think that that there has been change, but you have to make sure that everything is pristine from one year to the other, and you take into account any sort of PVD or motion artifact. These things are, I treat this like a self-driving car. Yeah, it can maybe do it, but I like to have my hands on the wheel. We really have to look at what we're doing here and make sure that the technicians got good capture each year before we can really apply what you just said. It's an excellent point.
Yep. Thank you. Another case of yellow disease, 58-year-old woman, yellow disease, slightly hyperopic, pressures are normal. Pay attention to the FLV, GLV. That's my little reminder of this. let's see, where am I? Right here. All right. So here we go. We have this patient here. We got 82, 82, and we're going to put them up together. And you're going to see 82, 81, 82, 81, 81, 81. I like this. Again, I'm not showing any superiority. It's just, I understand how this test works. I have this in my practice. I lean on this a lot. It's got a high sensitivity specificity. And it's saying, doc, it's not glaucoma, it's a general loss. And look how symmetric. 81, 82, but 1 micron, 0 microns. I don't get too concerned with the symmetry whenever it is so symmetric, especially superior to inferior and total. So totally normal, physiologically normal. Look at all this yellow. Look at all this red going on. But it's very symmetric if you would fold that in half and unfold it. And that disease typically doesn't do that. A 40-year-old man, red, blue, green disease, high myope here, 15 to 13. You can see now when I'm gonna put these together. Oh, maybe I don't put them together. Sorry. Let's go back. We're gonna look right here. You can see it's flagging it as red, 80, 78, 82. Oh my gosh, this gentleman has to have glaucoma. You come over here, it's 80. This is the left eye. 78, 81, saying it's not glaucoma, generally thin. This is a high myope. These thin GCC complex is now driving down this thin retina. But if you go and you look, everything looks the way it should be. You have this nice little classic, foveal pit here, nice slope to it. I'm not seeing any disease process. It's just a myopic, in a sense, eye. I go back, that was 2015. You come back to 2017. And the numbers, in a sense, are almost identical. And I have them here 22 months apart on this test. You could see here back in 2015, we had 80, 80. 2 years later, we have 80, 79, 77, 77, 78, 79. Look at the symmetry. And this is just because of the higher myope, they're falling out of that normative database, causing, oh my gosh, these retinas are thin, the ganglion cell complex, but it's just too symmetric in a sense to, really be high risk from disease. And then here's a patient with glaucoma or with diabetes, a 78-year-old woman, right? Again, look at how symmetric this physiological appearance is to her macula. When you go up and you look, 0, 1, 0, 0, 0. This is even saying, hey, look, it's focal, it's global, flagging it. So here I'm going to throw these proprietary measurements under the bus. It's just outside. You can see it's in the macula. Maybe there's a little RPE scar right here, but 77, 77, 78. This is too symmetric. Look at these numbers all through the retina, the fovea pit, everything's too symmetric. I'm just going to observe lots of green. A little bit of green, lots of red, lots of yellow, lots of blue, physiologically normal, too symmetric.
Before you go on, I've got a question, and I think this will help the audience. Now, you look at if you look at the individual maps there, all the red and the yellow. How do you interpret that? What do you put in your chart?
Yeah, I pretty much put, that the ganglion cell, because I have to interpret this, right? So, this is a wellness. How much do I interpret all my wellness? Yeah, I put in there that, that we have ganglion cell thinning, symmetric, most likely physiologically normal.
Yeah, and that's important because in our system, one of the drop downs we have is GCC, normal, abnormal, borderline, and you have to say this is abnormal, but you can explain yourself. You can't say that's normal. You can say it's abnormal. However, the degree of symmetry makes this likely an anatomic variant.
Perfect. So just showed a bunch of normals. So let's show some glaucomas here. Nothing really tricky here. These are just known glaucoma patients other than the first one that I start with. is going to be nothing tricky than maybe 5 to 10 patients with nerve fiber layer and GCC dropout. And again, we're going to look at this. You could see the outer rim, right? This is the axons of that ganglion cell. Remember, micro disc, there's going to be a little bit further distance, a macro disc. So sometimes these numbers are going to fluctuate. Depends on how close you are to that kind of those humps of that superior and inferior. Sometimes that bundle is split. Like you can see here, the bundle is split. Maybe it's all together down here. So we're looking at, the nerve fiber layer. Remember glaucoma, the prone zone, superior temporal, inferior temporal. Glaucoma is not a nasal and temporal disease. Superior temporal, inferior temporal. So this is kind of the area where we like to look, is these zones here, unless the disc is tilted, obliquely inserted. Now you got to kind of take it all into account. So this is your nerve fiber layer, and you can see here the T-snit. You can see how it looks good. Your average is 515, 518, 3 microns difference, 2 microns different, 1 micron different. Not going to really jump into the optic nerve head analysis. We'll jump down here into the ganglion cell. We kind of talked about it. 85 to 100. Now this patient's got a little bit of bonus. 102, 102, 100, 101. 104, 104, very symmetric, focal, and the global vision loss looks good. Normal. This is what we want to show you as a reminder of normal. All right, let's get into some glaucoma patients. Let's go into about 5 or 6 glaucoma. Just real quick, I can look here and look here. It's at asymmetric. Left eye is worse than the right eye. Let's jump into the nerve fiber layer. We have a 6 different, 15 difference on the superior. We have about a 5 difference on the inferior. Over here, we have a little bit of yellowing. Over here, we have some red. You can see that average superior. Look at this 74 in that glaucoma prone zone. You can see it's kind of down. It's not as green and red. And you come over here, look at this area versus this area. You can see the glaucoma. And just imagine that goes right over to that ganglion cell complex, which is, if I can move this circle right up here, you could kind of just see how that would just kind of translate over, and you have this area of this ganglion cell loss. And in this superior area, when we come down, the total's not too bad at 5 microns, not too bad inferiorly, but we have, look at that, whoop, whoop, there's a red alert. We have 15 micron difference. So if I was looking at this, I would say, okay, we got to explore this out. We shouldn't have this symmetry. And then we find out right here, you could see this superior, in the superior temporal area, this area is damaged as compared to this area right here. And you could see the difference, this asymmetry. This is a known glaucoma patient, obviously worse in the left eye than the right eye. Another patient here, going back, looking at the numbers, you can see the average is down, off by 12. The inferior is off by 20. We're flagging it here in the red. So we got some asymmetry going on. Jumping down here to the ganglion cell complex. Look, we have disease in both eyes. Glaucoma, glaucoma, glaucoma. You have disease. The total is off by 12. Inferior off by 18. It's really flagging it here. There's glaucoma over here. Look, this is where we'll say green disease, but there's disease going on. Look, you have your ganglion cell. It's just not outside where it's flagging it to be within normal borderline, but there's disease process here, but it's being flagged as green. So you got to be careful. There's green diseases that are out there. It's not always normal, but you could see here that we have a 4 and an 8 and a 6. This is kind of showing like, maybe it is a little bit symmetric going down, but look, it's flagging it in that focal loss volume, and you could see the asymmetry going on.
Hey, Greg, Susan asked the question, what kind of device are these coming from? which
Yeah, this
device
is-
are you using?
Yeah, this is coming from an OptoView, but these concepts could be applied to, to the Zeiss or to the Topcon units. And I'm not sure if there's anything else. Does Heidelberg have an OCT? I believe they do.
does.
So yeah, so it could be applied to any of these that are out there, but these are from the OptoView. No claiming no superiority out there. Again, jumping back to this, thanks Susan for the question. Jumping in, looking at the nerve fiber layer, just kind of looking at symmetry, everyone. 306 or 7, jumping down here, here's that question, nerve fiber layer first or ganglion cell? 11 in the total, here's 4, superior, not bad. So let's look at the inferior. Boom, look at this disease. Imagine this kind of this circle right here being pushed up. This disease in that glaucoma prone zone, you could see this area is missing, and you could see what has happened to this ganglion cell. So the ganglion cells were affected first. You could see it's flagging to here, highly suspicious, definitely suspicious over here. And you could see the little bit of the asymmetry worse in the right eye, this glaucoma, but you could see how this is kind of just arcuating right over, creating this defect that's out there. So the asymmetry that's there. You could do this over time. These are progression analysis. The reason why I put this one up here is because I would scratch my head a little bit on this one. If you remember, when we do the ganglion cell, the patient looks right at the light. To get the nerve fiber layer, they have to look nasal. They have to rotate that eye over. Look at that dot over there in the corner as the technician or yourself is acquiring the technology or the measurement. I usually like to see the macula, since they're looking at it with their macula, to see a little bit tighter confidence interval. Why is it better on the nerve fiber layer than the patient looking straight ahead at the macula? I typically like to see it like this. The confidence interval is a little tighter because they're looking right at the light, and maybe a little bit wider. So maybe there's a bad scan in here, but what we're doing over time is just seeing if there is any accelerated loss. We're looking for that line to go down quickly, and these progression analysis are good in these known glaucoma patients. Like this is what I wanted to show. This is typically what we see, right? The ganglion cell confidence interval should be nice and tight. They're looking right at it as opposed to looking off to the side. And we're just following this patient. This is probably a glaucoma suspect patient, maybe a ocular hypertensive. Everything's looking good in this right eye. Or over here in this left eye, we can see the disease that is created now in the asymmetry. So that has occurred. So this would be 82 to 81 versus 92. And we can see how that superior temporal is comparing to that inferior temporal. So these, again, remember, these are all glaucoma patients, worse in the left eye than the right eye, using the trend analysis that's out there. You can see that this gas gauge is still, the scale is 120. This is 120. Look where this gas gauge is sitting here at 80, say 2, and this one's up here sitting at 92. So maybe we caught it early enough, maybe we're treating it, or maybe it's just maybe like a secondary glaucoma. But just by looking at this, you could see the disease is worse in the left eye than the right eye. I don't really even see any disease in the right eye.
Greg, a question came in. What rate of change in the RNFL and GCC makes you worried about progression?
Yeah, that's a great question. I believe, I think the numbers are out there that you're allowed to have like a quarter of a micron every 1 to 2 years. I kind of use the instruments, they'll flag it here. Then I got to check to see if it's, the rate is kind of due to a disease process or is it due to scanning. Joe, do you have a more definitive answer than a quarter of a micron every year or two?
Well, I think that overall, it's hard to get that tight. These are coming from studies with trained observers and trained technicians. I think if you start looking at about 5 microns, we have to be aware that and look at the other things, the risk factors, the pressure, the visual field. So that that sort of is what makes me a little concerned, because there's also reproducibility of a couple microns, so you can have some fluctuation. But once you start hitting like 5 microns or more, I'm looking at other things as well.
And just be careful with that rate of change, Timothy, out there, because, we could see things change pretty quickly because remember, PVDs are around that optic nerve head. I saw someone change 15 microns and it's great. I have it on. I should put it in one of the lectures. The patient had a PVD impending. It was pulling on the nerve fiber layer. They come back a year later. They're 15 microns thinner. The rate of progression is a change of 15, but the PVD released and it took the traction off. So remember that, there's a lot of dynamics going on with these instruments, especially glaucoma being, a disease of aging in a sense. And then you start getting changes to those vitreomacular adhesions, tractions, and around those PVDs, that optic nerve. This is just showing here a glaucoma suspect, the strong family history that's out there. And we're just following this patient, good symmetry over the years. You could see we're using the progression analysis and just how we can follow these patients, good T-SNPs, and so on and so forth. But you can see here, it calculates the rate of change. This is saying 0.04. This one here is saying, 1, micron per year. And once it gets above a certain level, but look, it's going up, it's 1 micron. We're not growing nerve. Over here, that's a positive slope. This is a negative slope. Here's 0.55. It's not really flagging. It will flag it as purple. That's kind of what I go by when a flag. It's saying, hey, it's going down a little too quick. And then maybe I go back and look at the scans. Here's one here saying 0.7 microns. So we kind of, see them over the course, being kind of nothing to about, 0.5 over the year, 0.75. Just want to make sure that they're not going down any quicker, 1, 2, 3 microns in a per year time. So we have a question: if there's a 5 micron change, in how many years would you consider treating? Yeah, again, Amy, that's just a tough one because those changes could be from a lot of the dynamics. Let's make sure it's, from glaucoma. 5 micron change, yeah, it's definite. If we can say, hey, the pressure is 28, you're seeing nerve fiber layer, I would say just, treat it based on that, but make sure it's from the disease and not from kind of these physiologically abnormal scans that are out there. Joe, anything you want to add to Amy's question?
No, I agree. I see a change. That's a significant change. A change like that, you're going to repeat it. You're going to repeat the field. You're going to look at the optic nerve, and you can do the photos, and you're going to look at the risk factors and say, does this make sense? Was this a fluctuation? Is there bad data, or is this actually a true physiologic change?
So as Joe was answering that, I launched polling question number 4. Which of these scans is most likely due to glaucoma? Is it A? Is it B? Or is it both are from glaucoma? So as we're doing that, let's walk through. Let's walk through this. I hate this mouse. It's sensitive and it moves. So we can go through here and we can see inferior is 7, but we jump down here, 18 and 11. We see this big area, which corresponds to this. This area corresponds to this. We come over here, we see 82, 81, 82, 81, 81, 81, flagging as yellow. We see this loss, but this little island matches this island, this little red, a little bit yellow, little yellow. A, B, or both. And I'm going to end the poll, share the results, and I agree. A is most likely from glaucoma. This is that original one that I showed you where 34% earlier said that this was glaucoma. 24%, I think, said no, and 43% didn't know. So this is that original scan that I showed you. This is just too symmetric. And again, I'm not giving you any other data, so I get that part. But just by looking at the two scans, this one here would cause me a little bit of heartburn that I might want to go back and look at the nerve, see what's going on. This is just too symmetric for me to say it's most likely due to glaucoma. This is physiologically normal, just outside the normative database. And as Joe said, you would flag that as being, an abnormal GCC, but normal, most likely just due to physiological changes. So I see that we have 61% that said yay. We got 61%. Only a handful fell for that one again, and we have a handful saying both. All righty, what do we have next here? So learn what looks like normal. I guess we're going to move into some angiography here. And so we're going to jump into angiography for glaucoma. I've been teaching angiography since it came out. So I guess it was 2014, 2015. I was lucky to have one of the first instruments in the country. We watched this evolve over the years. So, what is abnormal? Well, I can tell you that I love my OCT angiography for diabetes. That's where it shines. Diabetes is a capillary disease. We as lecturers always say the crime must fit the punishment. What drives me crazy now, we have this technology and we're following patients with diabetes by looking at B scans. So that's really where angiography shines. It does really well for looking for choroidal neovascular membranes, these occults. The problem is with that is the technology is a little bit ahead of what we should do with these. They're doing studies on what should we do for these non-exudative occult choroidal neovascular membranes. It's good for glaucoma. It's another piece of data. Great for diabetes, awesome for diabetes, stellar for diabetes, great for macular degeneration, good for glaucoma. I like it because it gives me another metric. Do I need to add a medication? Do I need to send for surgery? Is this patient stable? So what we're looking at here, what looks like normal, remember, we're looking at the nerve fiber layer, the ganglion or the axons of the ganglion cell. So all we're doing is measuring the vessel density. You can see some really nice vessel density here. And again, we see in the macula, we see some good capillary density. So we're looking at the superficial vascular complex. I can tell you that this is the nasal side because it's always thick on the nasal side than the temporal side. This is the temporal side, a little thinner. And when you see these, you're going to see that that they're a little bit, again, a little bit thinner on the nasal side. So pretty much symmetric around the optic nerve. And we're looking at, and it's percent of capillaries. That's what you're seeing here with these color codes. Are they now reimbursing OCT angiography? They really don't have a separate code that's out there for OCT angiography. You could bill for it because since there's no code, I really don't do that. I'm usually doing B scans. I do a lot of wellness with my OCT diabetes that's out there. So there's really no separate CPT code that's out there. So are they reimbursing for it? I guess indirectly by using it as a retina code that's out there. Maybe something will change in that arena. But to me, the data for diabetes and macular degeneration and glaucoma is valuable. So, sometimes I guess we just have to take the hit, or you can charge the patient. I'm not a practice management guru. We'll have Joe on here in a few weeks, Joe Deloach. So now let me just show you what it starts to look like. So you have normal. Here's some glaucoma patients. You can kind of see that arcuate defect. Here's an advanced glaucoma getting into the macula where the ganglion cell complex is. You could start to see the capillary dropout. And the one nice thing here, and I believe, again, not showing superiority, I believe OptiView, and I was just at Vision Expo West, but wasn't able to get to all the OCTs to see if there's anything new. But they're able to measure when they have this angiolytics. That makes it nice to be able to, again, measure over time to see what's happening to that capillary density that's out there. So, again, remember in glaucoma, we were looking at this, this nerve fiber layer, this axon, this ganglion cell relationship, kind of seeing what's happened here. In this case, look, this is a glaucoma patient. You could see the ganglion cells affected before we're really showing up in the nerve fiber layer, but it's not always that way. But you could do the same thing here. Notice how this is coming right out, this capillary death. So the question begs now, do you get capillary loss first, then it kills the axon, and then it kills the ganglion, like this over here? Did you get ischemia first, then it killed the ganglion cell? And I can tell you, I've been doing this for a while. It happens both. Sometimes we pick up some thinning to the capillaries before we see the death to the ganglion cell, and then we see the death to the ganglion cell layer and the capillaries. So it didn't really help us unravel, is this an ischemic disease, is it a mechanical disease? It's just another piece of equipment. So how does OCT-A change the way we see glaucoma? It shows early changes in the retina and optic nerve. It's a new information to diagnosis. It aids, really, to me, in progression. That's really where it helps me out. Is this patient progressing? Am I needing to add another med? Do we have to send them for an SLT? Do they need a trab? It helps me out with what's happening as another kind of structure, GCC, and nerve fiber layer. We have capillary density, structure, then we got visual fields kind of as our functional measurement that's out there. So just to kind of review what normal is. Now, let me step back because I maybe lost a slide. Maybe it's hidden. Maybe it got deleted. Maybe it's coming up here. Let me just see real quick. I'll tell you in a second. Nope. So what I want to point out here is, do you need to inject dye? Do you need to inject dye to be able to do OCT angiography? And the answer is no. There's no dye needed. All these images are based upon 70,000 scans per second. Remember the original Stratus that came out by Zeiss? I think it was about 15,000 scans per second. So now they're up to 70, even higher, 120,000 scans per second. And when you get 1,000 and you get 70 to 120 scans in there, you're able to subtract out what's standing still to what's moving, and that would be the blood. And luckily, the blood cells, the red blood cells, white blood cells that are moving through those capillaries are larger than 5 to 6 microns. So it's able to pick up, and the algorithms is able to subtract out, and you're able to see the vasculature. So here's a 25-year-old man. This was one of my students at one point. We just scanned him, really healthy guy. You could see the nice capillary, radial papillary plexus. You can look at the numbers, 51 and 46. And the same thing goes with the symmetry here. You're kind of just looking at symmetries too when you look at these numbers. And again, here's his ganglion cell complex. You can tell it's nasal here, a little thicker, a little thinner on this side, and you can see the numbers. This is one of my partners in the practice, healthy, not taking any meds, likes to work out. You can see he's got a vitreomacular adhesion, not vitreomacular traction, but vitreomacular adhesion. But you can see that his age doesn't make a difference. Nice, healthy capillary, 52, 53. And you can see, again, this is the nasal side. And we're looking at the capillary plexus for these patients. You can montage them. This is kind of showing off. You can see all the blood vessels, starting with the optic nerve, going over again. There's your foveal avascular zone. That's really where diabetes really shines. And that's the right eye, and that's his left eye. All right, you can put them side by side. All right, let's talk a little bit on visual fields. The reason being is because we're going to go through some case studies here in a few, and we might as well just kind of talk about the visual fields and do some case studies and pull it all together. So bonus on visual fields, this is a 50-year-old woman, recently moved to the area to follow for her ocular hypertension. I thought that was kind of neat. She was diagnosed 18 months ago. She's on Travatan. Her visual acuities are 2015. She's got some slight hyperemia, and her pressures are wonderful on the Travatan at 13 and 14. These are her optic nerves. She's ocular hypertensive, so I don't really see any violation to the isn't rule. Inferior is thicker than superior, nasal, temporal. So I don't really see, but remember the ocular hypertensive treatment study said large cup to disc ratio or vertical diameter. So, or vertical, what am I trying to say, Joe? Help me out.
Vertical cup to disc ratio, vertical
Thank you.
elongation.
Vertical elongation, cup to disc ratio. There we go. Thank you. So that came out of the ocular hypertensive treatment study. So review of the records. Her diurnal IOPs are 16 and 19, 17 to 20. My point that I want to point out on this slide is she doesn't have ocular hypertension. She was never ocular hypertension. Couldn't put this patient in the ocular hypertensive treatment study. But what happened was thin corneas. Thin corneas at 19 and 20. Ooh, you must have a pressure of 24, 23. Now you have a pressure of 23. They said, oh, thin corneas put you at higher risk, and you have that vertical cup to disc ratio. And so now the patient got labeled as a high risk ocular hypertensive patient, but never had ocular hypertension. You know, Dr. Bennett likes to say he's the only optometrist. I always tease him. He's a good guy. I see him at the OGS meeting. I was there 1995, 1996 doing my residency as they were recruiting people at PCO, and I was able to put patients into that study. So I am an optometrist that was able to get people into that study. Here's a nice little nasal defect, right? So this patient is supposed to be ocular hypertensive. So we take a look and you see this mean deviation of minus 5.14 and a pattern standard deviation. Nasal defect. This is the left eye, right eye. I showed you the nerves. And so the patient had a pattern standard deviation that was somewhere in the ocular hypertensive treatment study. That's how this patient ended up on medication. But if you look at, I hate when patients say, or I hear lectures say, or this is all you got to look at, pattern deviation. Well, then why don't they just print this out and just give this to you? You got to look at everything, pattern, total, look at the raw data, look at the grayscale. Joe does a wonderful job saying, look at the grayscale, finding neurological disease buried in with glaucoma disease. So the reason why they give you all of this is to look at it. So whenever we look at this, you can see these are all zeros. Then there's a 24. Well, glaucoma doesn't go 29, a very dim light to the brightest light, very dim light to a bright light. This is probably a rim defect or a nose block, something going on. You can see how that just looks like that right there. So, what does mean deviation tell us on a visual field? Mean deviation tells us really simple how deep it is. And pattern standard deviation tells us how localized it is. So how deep, how localized. I can look at these two numbers right here, and I can tell you that it's a very mild defect, diffusely scattered throughout the visual field. That's what those numbers tell us. If I go back to this one here, I can tell you that this is a mild defect. 0 to 5 is mild. 5 to 10 is moderate. Anything above 10 is severe. And it's very localized. It's coming from these 1, 2, 3, 4, and this one right here, 5, and this one's 13, 6. These 6 spots are creating that mild. It's very localized. That's important in glaucoma, pattern standard deviation, because it usually keeps grinding down and creating that arcuate defect. This could be confusing because it's this right here that's causing this pattern standard deviation. All right. So the question I like to have is, I'll click through this, why is this patient being treated? So I said to the patient after reviewing, let's stop your medication. Let's repeat your visual field. You can see how old this case is. It's a GDX. And so that was way back in the day whenever, the ocular hypertension treatment came out. And so I said, okay, repeat the visual field, stop the medication. and let's get a GDX. And I used to always tease Alcon, look, I stopped the Travitan, this was even before Travitan Z, and look, the visual field defect. Oh, don't say that. Don't say that. Well, I don't think docs are going to believe it. It was just a joke. But anyway, if you take a look now, this defect went away. It's now a very mild defect. It went from a 5. And this tells me it's very diffusely scattered throughout the visual field. And look what happened. The numbers went back to normal. So we just got a reliable visual field. And then we look at the GDX, which doesn't even take into account ganglion cell. And you can see, though, if you come down here to the T-SNP, it's very symmetric, very symmetric. Again, we can use what we taught a little bit earlier, symmetry. We have 62 to 60. We have 64 to 62. And then it was all about this number. I forget if the number was closer to 50 or 60. You had to scratch your head. It was all about the number. But you could see here that this nerve fiber layer, but the patient was ocular hypertensive, right? That was her diagnosis. So we shouldn't see any damage here. But this patient was backdoored into the ocular hypertensive treatment study because of the very thin packs, the vertical cup to disc ratio, the pattern standard deviation. So this patient couldn't even be in the ocular hypertensive treatment study and was just being overtreated, but it also gave me the ability to discuss visual fields. Joe, do you have any questions?
No, I was going to comment about backdooring
Comments.
them in, and this really underscores why you don't make the conversion. All right, so the pressure is 19. They got a 505 cornea. So if somebody makes a correction and it goes up to, I don't know, let's say 23. Now the patient goes to another practice, right? And the old record says pressure is 23. Doctor sees a 505 cornea. Now they make that 23 a 26. And before you know it, the patient has sky-high pressures and they're perfectly normal. Depending how many times they overcorrect that.
Yeah, that's true. You put, if you make the correction and you don't put the 2 in there, right? Yeah, that's a good point. You put in, whatever they were 20 and you say, okay, I'm going to raise it to 23 and 24. That's what you put in the chart. If you don't put the 20 and the 20 in there and say, okay, I'm going to cause it to increase, and they go to the next stock, yeah, they could be 40 by the time they're done.
It's like when I was at university and teaching my glaucoma service. I can't tell you how many times a visual field would come to me, and I look at the at the data, and I see the trial lens is a +9. I'm thinking, I don't remember that patient being so high. And apparently, the student would take the last RX that was given and say it was a +3, put that in as the distance RX, and told it, add 3 more diopters and 3 more diopters. Before you know, the patient's up to 25 diopters.
They're doing a Goldman bowl behind their eye.
Yeah, hence the reason I'm in private practice now.
All right, let me throw this one out to you guys. So we have a visual field here. And what's the mean deviation of a blind eye? So patient comes in, never hits the button. What's the mean deviation? And this actually came to me during a lecture. I was doing a lecture, and I was like, man, I'm treating glaucoma. I'm doing a visual field lecture, but I don't know what the bottom is. So what's the mean deviation? So it was really fun. I came home and I really couldn't wait to get back to work. I walked in, and the first thing I said to Sarah, turn on the visual field and let that visual field, put in 35 years old and just let it run as the patient's blind. And she looked at me and said, yeah, just do it, and printed it out. I'm like, oh, this is great. I'll go change it for me. Put in 65. So let's see here. What's the mean deviation of a blind eye? Let's end the poll. Let's see what the audience is saying. Attendees tonight. We have some plus, we have some zeros. Remember, 0 should be, I'm going to go back to a visual field, or maybe go to this one here. The mean deviation of a blind eye is on this 35-year-old is 34. But if you look, remember, I told you, this tells you how localized it is. It's scattered throughout the whole visual field. That's why this is very low. So, the answer I was going for was 32, because if it's a glaucoma patient, they're usually a little bit older. Here's 65. Here's minus 32. So when I'm treating glaucoma, remember 0 on this polling question should be 0, should be normal. And then it goes to -5 and then -10 and -15. But what I wanted to know is what's on a 24-2, what's the mean deviation? Well, it's about -32. So when I'm treating glaucoma, I really don't want to get to that -30 range that's out there. In the OGS, they said 0 to 5 is a mild defect. In the 5 to 10 is a moderate defect, and 10 is a severe. And that's kind of how I set my target IOPs. This has kind of stood the test of time, is that if I get up in the worst eye, if it's a 5 and the other eye is, a 2, if the other eye is a 6 and the other eye is a 2, I go with a 40% reduction. So I use the mean deviation 30, 40, and 50. I usually don't set my target IOP until I get a reliable visual field. It just kind of stinks if I don't. That's kind of stood the test of time. Someone comes in and they're already a 10 on a visual field. They should have been in years ago. And the pressure is 30. I'm going for 15. And that's just kind of my target that I go for. How many decibel difference between the two eyes? It's about a 3. So this is what I kind of teed it all up for. Joe, any other comments, questions? You want to make any comments on visual fields before I move into some case studies here, and we'll try and get it wrapped up right on time.
No, we're going to do a formal visual field with interpretation in a couple of weeks. So I'm going to let that all stand and get on to your examples.
Okay.
But Lynette wants to see the last slide again, I think.
Okay. So again, you do visual fields on both eyes. They have glaucoma. Both are 2s, or 2 and a 4 because it's asymmetric. I'm going to lower by 30%. One's a 2, the other one's a 6. That's moderate. I'm going to go for 40% off of that peak IOP. So this is just a way of using visual fields to help get to set a target IOP. All right. 68-year-old woman with glaucoma wants a second opinion for her glaucoma management. Recently had cataract surgery. She has an eye stent on September 25th, 2017. She's currently using dorzolamide and Lumigan in the left eye. This is the eye she had the eye stent. So our practice, I came to a different surgeon. This was done in the Philadelphia area. She kind of lives in the Harrisburg area. And so she came my way to hey, I hear you understand a little bit about glaucoma, blah, 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 blah. Wasn't really happy with what was happening here. So we ended up doing a Cahook dual blade on July 24th, 2018. And her pressures were 12 in the right eye and 16 in the left eye. I still keep a paper chart for my glaucoma patients, even though I am electronic, and I still keep a dashboard. DFE, visual fields, OCT, gonio, photos, packs, and OCT-A. eye stent, make a few notes. And then every time I do a DFE, gonio, photos, I kind of keep track. So I still keep a paper chart. I like to flip. I like to see. It's just not all electronic. It's all my glaucoma patients. I did pachymetry on her. So I wanted to see, what are we up against? Thin cornea, thick cornea. Really, doesn't really tell me much. 575, 560, 586. Now here's her OCT. And again, you could tell real quick she's worse in the left eye, right? This is the eye that has the eye stent. We get the better eye when she comes in. Good news is we're able to do Cahook dual blade. But let's take a look. This is a known glaucoma patient. Let's go look at the nerve fiber area. Look, 17, 20, and 14. Look at the asymmetry that is in this nerve fiber layer. You can see it's a inferior temporal, superior temporal looks good, superior temporal damaged here. So we're still pretty well preserved in the right eye, superior temporal, in that glaucoma prone zone that's out there. Go down to the ganglion cell complex. You can see inferior 13, the 5 and the 9. So you could see that those rules that we taught earlier, the asymmetry is there. You can just kind of see with the colors that it's worse in the left eye than the right eye. You can see what's happening down here with your axons. Again, that's what we're measuring, the nerve fiber layer, the T-SNP. That's what they call this up here, the T-SNP, temporal, superior, nasal, inferior temporal. And we kind of want to look in that superior temporal and inferior temporal zone. You can see just how it's been pushed down, but you can see the asymmetry. Here's our visual field defect. You can see it's a 92%. Look at this, minus 1.62, but she's a 6 over here. So this is moderate. If I knew her peak IOPs, I would set it as kind of a 40% reduction. If she was just walking into the room, I'd go with a 40% reduction. That's kind of how I use that. And you can see this nice little arcuate defect, but what I don't like is I don't like how close it is to the macula. Look at this kind of split fixation that she has in her left eye, and she has this kind of defect right here in her right eye. So don't really like that. Maybe go a little bit more aggressive with that IOP that's out there, but you can kind of see how this is all kind of lining up, structure and function. And all I want to do is kind of show you what it looks like on angiography. This is, again, just another piece that it adds to me. Remember, it's worse in the left eye. Look at this nice wedge defect. This is nerve fiber layer here. You can kind of see what's happened to the nerve fiber layer. You can see this nice big wedge defect. Look how the capillaries have dropped out right here in this patient. And then we have this right here, right here. That's showing the glaucoma. And you can see how it's just a wedge defect in the nerve fiber layer. Again, asymmetric, better in the right eye, worse in the left eye. So here is an enfos, just looking at, you can see the wedge defect here. This is almost kind of like using your nerve fiber layer defect on your photos. You can see a nice little wedge defect right here. You can see the capillary dropout in that area. You can see the capillary dropout in this area. This is just using and clicking on this little button right here, enfos. I use this a lot. So, I like the idea of being able to use angiography. A lot of times it just helps confirm, gives me kind of a better look at what's happening to these tissues and structures that's out there, using photos, using visual fields, using OCT-A, using, OCT that's out there. And here's our angiography of her macula. Remember, she has that defect that's worse in the left eye. You could see the larger capillary dropout. Joe, here's kind of your nautilus shell. I'm able to kind of apply that nautilus shell type of, or that window wiper fluid, that windshield wiper type of scrape down. There's your nautilus shell, kind of the nautilus shell here that you've kind of coined over time. It's kind of wiped out from here down. This is kind of a structure. This is a vascular test here. And then this is kind of cool, right? I don't always do this, but you can see this little montage. Look at how this kind of rolls out. This is the eye that's a little bit better. And I'll show you the left eye. You can see the nice big wedge defect. And you can just kind of see how this capillaries have dropped out. This is a PVD right here. This is what Joe was mentioning. Sometimes you get some, some artifacts, and there's a PVD. But you could see here how the glaucoma, and I hopefully have them side by side. Glaucoma is a nice little arcuate defect. You can see how it creates this visual field defect, and it's worse in that left eye than right eye. And I didn't get to scan it in here. She sent me a really, really nice. She's getting a little bit older. It's hard for her to drive this 2 hours. I'm going to scan it in there because I'm not going to be able to follow her up anymore. Because I literally just got it in August, a letter saying, "Doc, thank you very much. You've been wonderful. You've saved my vision. I need to stay closer to home." But I do have some updates from 2021. I'll get this updated and then kind of scan that letter in there. But you could see that the glaucoma is worse in that left eye, right eye. This tells me that she has implants, right? With the Optomap scan, you can see she has some PVDs. And if we go kind of to these kind of red-free, you could see the little defects. Look at this big defect that's here. You could see the damage that's to this left eye. And we can see how we followed her over the years. how she's 2008, 2019, 2020. Let's see, I don't have any other visual field. I probably can update that. Probably got one in 2021, 2022, and how we're just kind of following her glaucoma. You can see here the rate of change in this right eye, in this nerve fiber layer. When we initially scanned her, it's not showing up here, but you could see that was before the Cahook dual blade. So this is the original, but you can see that if I would take a line here, it might start to flatten out. And you can see the rate of change at 2.56 is flagging it. But you also kind of have to know where you intervened with treatment, right? This is where she came in originally. Then I sent her for a Cahook dual blade, and it seems to be flattening out as we're seeing over here in the more reliable macula, despite the confidence interval being a little bit higher. So, and this is the, the other eye that was done with the eye stent, a little bit going down. It's flagging it 2.02, microns per year. Over here in the ganglion cell complex, it's saying it's pretty stable. And then this is just using, again, going and looking at the angiography, right? It's giving me another piece of information. I scanned her in 2019, and you could see we got some, this is her right eye. You could see down here, blue is the right eye. She's going across with her superior retinal nerve fiber layer. This is the inferior nerve fiber layer. This is a nerve fiber layer scan. Now I can go and look at her angiography. And her angiography from 2019 has gone up. And sometimes that's what happens when you take the stress off, right? The eye can heal. I've seen that. Remember, this is before surgery than after surgery. And then you can see this is the eye that's more advanced, kind of putting along here. So you could see that I'm pretty pleased using, 41 and 37, 46, 51, and that's going, 2 years later, using angiography to help me determine, is the patient progressing? I think we're doing really well in the right eye because we got an uphill trend. You can get healing when you take those stressors off that's out there. And then here's what she looks like again in the kind of that structural change. You can see kind of cruising right along. So this is, we've seen this before, kind of the ganglion cell. This is another way of looking at it. This is using the angiography. You can see right here, clicking right there on GCC. I'm going to go down here and start clicking on vessel densities. You can see right here, superficial density. And how is she doing? Well, we took that stress off, did the Cahook dual blade. She kind of went uphill. And that's in the superior, took some stress off, maybe where there was some damage. There was already damage inferior. So she's just kind of cruising right along. So I'm kind of concerned, at the point, is she progressing in that other eye where she had the eye stent and she's still using glaucoma drops. But then you come and look over here at this, the right and left eye. You could see that they're kind of, this one's coming down, this one's coming up, and they're all kind of meeting in these different areas. And I'm looking at the deep plexus, superficial plexus, a little concerning with that left eye. You come over to the deep plexus, they both look okay. So again, there's just a lot of data to be able to look at. I know we're getting close here, so I'll go through these last few cases and get done. Here's a known glaucoma patient. You can see I'm using my dashboard here, making sure I'm getting all the DFEs in a timely manner, visual fields, OCT. You can see I've added OCT-A, and here's his baseline IOP. Look at that, 38 and 35, setting my target at 20. He's got glaucoma worse in the left eye, using Lumigan and Combigan. So let's take a look at his visual fields. Let's see, worse in the left eye than the right eye. So that's why I put the visual fields in here. So he's sitting at 96% and 100%. Remember, it's worse in the left eye. Looks like there's a huge blind area here, but we could see it's only a minus 1.3. That's why we have to know what the mean deviation is. This looks terrible. It's very diffuse. It's a nice little arc. It's a nice little nasal defect. Man, how bad is that? Minus 32 is a blind eye. Oh, it's only -1. Final little comment. 16 is not half blind. It's not linear. About 10 is about half blind. That's why they consider it as a severe defect. All right. So let's go and take a look. How are we doing visual field wise? He's doing well over the years. You know, he's down a little bit, and it's saying in 5 years, you know, if you look at these last few where we started really aggressively treating him, he's got a little uphill trend. So it's saying, okay, doc, you know, in 5 years, he might be here, but we're doing pretty good. He didn't have the defect. He's got the defect now. And over here, he's plugging along. He had a bad day right there. Someone asked in the last, do we repeat it when they have a bad one? Absolutely. I repeated it that day and got the better visual field. He just kind of, yeah, mental pina colada, as Joe would say. Here's his OCT, GCC. He's asymmetric, right? Let's go back and look. 13 here. He's a 13 here. I don't like when there's asymmetry. Look at the nerve fiber layer now. Nerve fiber layer is outpacing the ganglion cell complex. Nerve fiber layer is outpacing the ganglion. It's neither one. Ganglion cell sometimes, nerve fiber layer sometimes. That's why all these measurements are on here. And now we can add in some angiography to it if you'd like. You could see he's doing well with progression over time. I could probably get a few more scans of him. Remember, his glaucoma is worse in his left eye. Remember, I have these up here, what normal looks like. You could see the superior loss that you could see in the angiography in the left eye, but you can also see some here in the right eye. And then we come over here to the ganglion, or to the ganglion cell, looking at the peripapillary capillaries, or the capillary density in the macula. Joe, there's your nautilus shell right there. This is left eye. You can see right where that capillary dropout is. And so not really seeing much here in the montage, and really not seeing much here, maybe showing up. And that's why it's hard when you don't have the ability to do the angiolytics that's out there. I thought this was kind of cute. I was reading my patient chart online, which was emailed to me right after my visit. I noticed that you have me down as 344 pounds. That's incorrect. I'm 333. I'm holding steady. Sounds like a lot, but this guy is a power lifter, so he's really concerned. I like how he said, look, I'm holding steady between 332 and 334. You can see it. It happens. They read their charts. All right, here's his optic nerves. You can see here, not too bad on that right eye. There's the damage on the left eye. You can see it right up into here. And there it is right here. So there's his visual fields to date. You can see we're holding good with the right eye. It looks like we're really going downhill, but not really. This is only a minus 1.6. It's not 32. Here's how we're doing with the GCC over time. You can see this is the right eye holding steady. And then we're actually going uphill here with the nerve fiber layer. And going 2017 to 2021, you know, about 5 years worth of data there. Here is his other eye. So, you know, is this rate of change at 0.64 microns per year? It's flagging it, saying, hey, doc, keep an eye out on that, on his nerve fiber layer. And we come over here and we can take a look, but in his GCC, he seems to be hanging okay. So I'm not going to really make a whole bunch of decisions. Someone asked here, look, 0.64 per year is flagging it. We can see what's happening here with the nerve fiber layer. Again, getting some more nerve fiber layer. I click that right here. Here's what he looks like. Again, look at the left eye compared to the right eye. You could see that there's more damage, and it just gives me another metric to be able to follow this patient that's out there. And Joe, there's your nautilus shell again, looking pretty similar from 2018 to 21. All right, so let me just go to this last case, and this is how we're going to wrap it up. This is a fun case. This gentleman is a physical therapist. He is ocular hypertension since 2014. I used to do glaucoma in another practice. He doesn't want any treatment. He understands the risk benefit. He's pigment dispersion. When I do gonioscopy, it looks like someone drew with a Sharpie to his trabecular meshwork. His IOPs are now 32, and it might even be higher, 32 and 30. He doesn't want treated. So here we go. Here's his visual fields, 199%, 100% clean visual field. Here's his GCC. oh my gosh, what are we doing here? Look at all this red. Does it meet the criteria of the symmetry? 0, 1, and 2. It's saying it's not glaucoma, it's just general loss. Look at the symmetry between his T-snit. This did not cause me to say he needs to be treated, even at a pressure of 32. His nerve fiber layer looks good. His nerve fiber layer is good. This is too symmetric at 81, 81, 80, 79, even though it's flagging it as red. Let's keep moving. Here's his radial peripapillary capillaries. I saw him in 2014. I didn't start doing angiography maybe till a year or two later. I was like, oh my gosh, please don't be a defect. Please don't be broken. And it wasn't. Nerve fiber layer looks good. Capillaries look good. Here's his macular capillary complex. Maybe looking a little thin, but it's a 7 right here. That's not good. I like for them to be 8s, 9s, and 10s. Capillary angiography is super, super sensitive to the quality score. Here's his montage looking beautiful. Here's his montage looking beautiful. All right. Here's this IOP. This is the 2021 update, and I got to do 2022 update. You could see that his pressures by Goldman, 26, 26, 30, 32, 35, 26, 30, 31. And then we got the Aura ocular response analyzer, 38, 32. Goldman would be 40 in a sense, 39.2, 34.7. His cornea hysteresis is good. There's his nerves. There's his nerve fiber layer, red free. And then here he is cruising along. Here's the nerve fiber layer straight across. Ganglion cell straight across, despite these flags, right? It's too symmetric. Look, over 2018 to 20, 81 to 82, 80 to 81, and his nerve fiber layer is looking good. Let's see, where am I on this? There. Let's see, flagging it here, going downhill. Someone asked about flagging it. Here's 1.46 going downhill. This one's going slight uphill. This is 0.7. So is he getting damage to his nerve fiber layer at pressures of, say, 35? How's he doing when we look at the radial pericapillary capillaries? What 18 to 20? Looking pretty stable. This right eye is going straight across, left eye is going down. Nothing really definitive here with his scans. Here's his capillary plexus in his macula, 18 and 20. Here's 2018 and 20. We have the right eye coming down a bit, the left eye going up, kind of meeting here, one down, one up. Nothing really convincing here. Same thing over here in his macula scans, going 18 to 20, 18 to 20. And you could see nothing really convincing here. Walking around with pressures, pigmentary dispersion, pressures of 30 to 38, whichever you want to say. Here's the nerve fiber layer. Here's his GCC. So IOP's 38, 32, ocular hypertension. He still says, doc, monitor me. I don't want drops in my eyes. I don't want to have to pay for them. You've got the technology. You've got angiography. You've got GCC, nerve fiber layer, visual fields. You got all this stuff. If we start seeing trends, then you can treat me. So he has gone now almost 8 years of high pressures without having to be treated. And this is using kind of technology in a sense to help us do that. That's out there. So with that being said, Joe, do you have any comments? Because I want to land this.
No, I'm going to keep it short because we're right at 10 o'clock right now. So let's do a quick wrap up, I think, for our audience.
So is there any other questions? Lynette, can you show the last slide? Any thoughts on CATS versus GAT? What is CATS, Joe?
I don't know.
I know that there's this new MFAT type of tonometer out there. Not sure what CATs are, Mark. But the key is, NCT is probably not the way to go, but Goldman or these new tonometers, as long as you're getting a measurement and following them over time, you can measure the pressure, I believe, how you want. That's out there. So it's the new tonometer tip. Yeah, it's, I don't think there's really, Goldman is still the gold standard, but there's other ways to measure it. All right, I'm going to end the poll and say thanks to everyone. Share the results. Looks like everyone liked it, so stop it. And just say thanks. I'm looking at questions. Thanks everyone for taking this course tonight. This was OCT, OCT Angiography in glaucoma.